Hello, I'm Martin Dawes and I'm going to run through an imaginary case over time to show you how the medication decision support system TreatGx works. So I select the case and I want to see which drugs to give to this patient who has high blood pressure. There's no drug history at the moment, no medical history, patient's 56. We have poor metabolizer, whatever that means, of CYP2D6, some other genetics. Renal function is apparently pretty good, some elevation in liver enzymes. So, not surprisingly, the first medication list that will come up is for any of the major groups of antihypertensive medication: ACE/ARB, calcium channel blocker, or a diuretic. First thing to point out is that the initial dose has been adjusted for liver function automatically for those drugs that are affected. And what I'm actually going to do here is change the renal function. Let's say that it was a little bit worse. Automatically, the system is now adjusting the other drugs affected by renal. And you can see here that eprosartan is no longer included as a medication option because of both renal and hepatic dysfunction. Think about the genetics here. The first thing that you might see is that there's a risk of ACE/COF, and the ARBs are now higher up the list than the ACE inhibitors. As we go down, we'll see the diuretics, and here we've got hydrochlorothiazide, which is one of the most frequent prescribed diuretics for high blood pressure, and in this case the patient may have an increased response due to their genetic variant. So what I'm going to do is start this patient on diuretic for their hypertension. So I just put in the first few letters of the medication and they're now taking the apohydro. I see them again and they're not maybe getting the response I wanted. So what's the next level of medication that I could give them? Well, I could start them on irbesartan, for example, 75 milligram. And the dose has been adjusted automatically for concurrent diuretic use. I don't have to look that up. So let's do that. Let's start the patient on irbesartan. 75 milligrams. Let's see what the options are now. Patient comes back in, not responding as we would wish, and you can see that the system is now coming up with the calcium channel blockers. Now this is all right, but in the meantime, in fact, the patient has developed diabetes. So they're now taking metformin. So I'm just going to add the disease diabetes first of all. And then I can put the metformin in here. We'll just give them 500 milligram tablets. And then I can actually say whether it's tolerated, whether it's a previous medication, current medication. And go back to this. And I'm going to add the diabetes to medication list. And you can see that this has actually reduced the number of calcium channel blockers because not all calcium channel blockers are appropriate in patients with hypertension, and the algorithms already know that. So we'll give them amlodipine. And see what the next options are. So beta blockers are the next option, and you can see here the metoprolol is not included because the patient's got a variant with CYP2D6. There's some interaction automatically included. This patient has epilepsy and is taking valproic acid. And I can see here that there's a risk of QTc prolongation. So I might want to do electrocardiogram, just ensure everything's all right before I start this patient on the acipitolol or the bisoprolol. So let's start them on bisoprolol. And in fact, this patient is having a few problems with the diuretics, so I'm going to take them off the hydrochlorothiazide. and I'm going to put that into the drug history. So they've had a previous trial, and the next level of drug for this patient would be the alpha blockers, centrally acting agents, or potassium-sparing diuretics. So you can see this system is able to go quite a long way with antihypertensive medication. In fact, this patient during this period has also developed some heart failure. And again, the system is smart enough that it's able to pick up that they have this condition and now adjusted the medication in light of that. So what I've done here is demonstrate how the system can adjust for previous drugs, can adjust for medical history. It takes into account the renal, liver, drug-drug interactions all at once. And so even for complex patients who've tried multiple medications in the past, the system is able to include the information, and not only that, is able to adjust medications for the genetics.